Good afternoon. Welcome to UPMC's 22nd media briefing on the COVID-19 pandemic. Today, our clinical and scientific experts will share their expertise regarding the upcoming cold and flu season and its intersection with COVID-19. We're joined by Dr. Don Yealy, UPMC's Senior Medical Director and the Chair of Emergency Medicine, Dr. Graham Snyder, Medical Director of Infection Prevention and Hospital Epidemiology at UPMC, and Dr. David Nace, Chief Medical Officer for UPMC's Senior Communities and Clinical Chief of Geriatric Medicine at UPMC in Pitt. After their remarks, we'll take your questions. Dr. Yealy.
Thank you very much, Paul. At UPMC, we're not content to sit back and see what the future holds. We are always learning, we're innovating, and creating our own vision of what medicine and what healthcare should be. That's why we developed our own test for COVID-19 back in March when testing was limited. We also then printed, using a 3D method, our own nasal swabs. We were not waiting for the government or for industry alone to do the work for us. It's also why we've created new ways to do research called adaptive and platform clinical trials. This allows us to quickly and effectively give the best answers about how to care for patients with COVID-19. It allows us to help sick people even before those results go on to peer review, the normal scientific method. And as you saw last week when Dr. Mellers and Dr. Dimitrov shared their discovery of a drug that has the potential to not only treat, but also prevent COVID-19, especially in the most vulnerable groups of our communities, you know that we innovate and we create. So it should be no surprise that we're innovating even when it comes to our annual flu vaccination program. Last fall, long before any of us had heard about COVID-19, the UPMC Emergency Preparedness Team planned a large-scale mass vaccination of our healthcare workers against influenza for 2020. We thought this would be an ideal chance to simulate the likely scenario we'd face distributing a vaccine for any new virus during a hypothetical pandemic. We called this planning effort Operation One Shot. The goal was to improve on our existing high rates of worker vaccination and improve not only the rate of vaccination, but the pace of the vaccination. We wanted to find out what works well and what needs to be adjusted so that we could be ready for any new threat. The idea was that if there was ever a pandemic, healthcare workers would be one of the earliest vaccinated populations so that they could continue to provide care for you. Here we are now in 2020, and the situation we were planning to simulate is actually fast becoming the reality. Last week, hospitals across the UPMC system in Erie, in Western Maryland, Harrisburg, and here in Pittsburgh participated in this pandemic emergency mass vaccination drill. Most of our participating hospitals vaccinated considerably over 70% of their staff through Operation One Shot, with some reaching 100%. I want to underscore how impressive that is. Usually, we don't reach near 100% vaccination for flu among our healthcare workers for 7 to 8 weeks after an intensive immunization campaign. Operation One Shot vaccinated the vast majority of workers at those targeted locations in a matter of days. This achievement was possible due to the multidisciplinary expertise across UPMC. This includes experts in emergency preparedness, infection prevention, supply chain, employee health, pharmacy, and many others. And with the universal UPMC vaccination program for the flu, all of our healthcare workers who can be vaccinated will be vaccinated by mid-November. This increases the safety and peace of mind for our workers and for anyone who seeks care at our hospitals or our doctor's offices. We know how to roll out vaccinations faster now and how to do it more effectively by learning as we do, by always wanting to improve. Something I've said repeatedly during these press conferences and throughout the COVID-19 pandemic, at UPMC, we prepare for the worst, hoping for the best. We will base our actions on the science. Those are structured observations that we have and we take from others, but we'll also base them on the reality that we see here. Dr. Graham Snyder can tell you more now.
Thank you, Dr. Yealy. Throughout this pandemic, we've been transparent about the decisions UPMC makes and the data and the observations we're basing those decisions on. In a public health crisis, history has shown that open, clear communication with the public is critical. I have confidence in the intellect and integrity of the public health colleagues we directly partner with. However, changes in our nation's infection prevention and testing guidance are not entirely based on our evolving understanding of the SARS-CoV-2 pathogen. At UPMC, we make our decisions and recommendations based on the facts, science, and our clinical experience, wisely using the resources that we have, with the first priority being the well-being of the patients we care for and the safety of the healthcare workers and our staff, as we've always done. In the lay press, as well as the scientific community, the debate about the way this virus is transmitted is focused on whether it's transmitted by droplet or airborne aerosol. And this has resulted in controversy about whether the public guidance is right or wrong. The truth, however, is that the virus may be transmitted by both mechanisms. At UPMC, we've observed that the virus appears to be predominantly spread by large droplets. We have not seen direct evidence of airborne transmission in our controlled healthcare environments. Everyone in our facilities remains safe by taking precautions against droplet transmission all of the time, especially by wearing a mask and practicing physical distancing. We provide and recommend protection against airborne transmission in the situations where we anticipate it could occur, including, of course, for the care of patients who are contagious with the virus, but also for specific surgeries and aerosol-generating procedures in all patients. We've also heard conflicting guidance on eye protection. At UPMC, we make eye protection available for all patient encounters and recommend its use in situations where there could be a risk of transmission despite wearing a mask or respirator. Care of patients with COVID-19 and during the care of any patient where an aerosol may be generated or exposure to body fluids may occur are the situations where we recommend eye protection. Finally, test capacity, unfortunately, continues to be a limited resource. So we must use this valuable resource wisely. This means our top priority for testing is symptomatic patients and healthcare workers. Especially as we enter influenza season, it is essential that anyone who has symptoms of COVID-19 get tested. We do not routinely test people in our healthcare community who are exposed to someone with COVID-19 but who are not showing symptoms, the asymptomatics. If you are exposed, you could develop COVID-19 at any time within 2 to 14 days of exposure. A negative asymptomatic screening test within a few days of exposure does not prove that the person is not exposed, not contagious, or will not develop symptoms. The current federal guidance fails to address this reality. For UPMC healthcare community, patients and healthcare workers who have been exposed to COVID-19 will take appropriate precautions and be quarantined to protect those around them. But for the most part, they will not be tested unless they develop symptoms. I want to emphasize a few things. Avoiding situations where there's crowding without distancing and without masking is the number one way to avoid being exposed. If you've been in direct contact with someone who has COVID-19, it is important to self-isolate for 14 days to prevent further transmission, whether you have an asymptomatic test or not. It is critically important to get tested if you develop symptoms. Unlike UPMC, many organizations choose to change their practices with the frequent and fickle changes of our society's fears, heated debates, and political influence. UPMC knows from our contact tracing that our model of infection prevention and testing is successful at preventing transmission in our facilities. Now I'd like to turn to flu season. While we're preparing for the simultaneous challenges of a flu epidemic and COVID-19 pandemic, we are optimistic this flu season will be mild. Each year, the multiple ever-evolving influenza viruses that constitute the annual pandemic vacillate between the southern and northern hemispheres. Currently, countries in the southern hemisphere are approaching the end of their traditional flu season, and they're reporting good news. the infection prevention measures taken against COVID-19, such as masking and social distancing, appear to have diminished the spread of flu. If our communities stay strong and continue to do what we need to do to prevent COVID-19, this may help reduce the impact of influenza and other viruses. But that's not to say you should skip your flu shot. The flu virus infects millions, hospitalizes hundreds of thousands, and kills tens of thousands of Americans yearly. The vaccine is a safe and effective way to reduce the impact of seasonal flu. Getting the flu shot at UPMC is easy. At many of our offices, you do not even need to come into the building to get your immunization. Simply schedule an appointment with your physician or pediatrician and we'll come outside to you. At UPMC Urgent Cares, an appointment isn't needed. Just call when you arrive. UPMC is particularly concerned about one special population, the elderly. Over 90% of annual flu deaths occur in people aged 65 and older, the same group that is most vulnerable to COVID-19. And if you're young and healthy, getting the flu vaccine is important to protect your vulnerable family, friends, neighbors, and coworkers. As you'd expect at a major academic medical center like UPMC, we're fortunate to have one of the top experts on this subject, my colleague, Dr. David Nace, whose research in 2014 resulted in the high-dose flu vaccine being recommended for the elderly living in long-term care facilities. Dr. Nace?
Thank you, Dr. Snyder. Vaccines work by prompting our immune system to react to and produce antibodies, so that when the real virus shows up, or the real bacteria shows up, we're primed to attack and get rid of it. As we age, our immune systems don't work as well as they should. They don't mount the same robust response, leaving us less prepared. Studies have shown that in the elderly, the regular standard dose vaccine is anywhere from 17 to 60% less effective. So pharmaceutical companies have been working to create more effective flu vaccines for older adults. The first was the high-dose influenza vaccine. In clinical trials that my colleagues and I conducted along with others around the country, we found that indeed the high-dose flu vaccine did provide more protection for older adults. Since that time, newer vaccines have also shown that there is the ability to protect the older adult population better than the regular vaccine, including the recombinant vaccine that's being used at UPMC. The flu vaccine was invented in the 1930s, and yet it took nearly 75 years to come up with a vaccine that was better, though not perfect, for influenza in the elderly. Even though, as Dr. Snyder told you, 9 out of every 10 flu deaths in the United States occurs in the older adult population. Now, I'm as eager as anyone for a safe and effective vaccine that can protect us against COVID-19. And it would be great news if that vaccine worked just as well for the frail older adult population as it does for everybody else. But experience and a long trail of science tell us that this likely won't happen. And since the elderly are the most vulnerable to COVID-19, that is why the developments like the one Dr. Mellers and colleagues told you about earlier this month is so important. The drugs that they're working on are monoclonal antibodies, and they do not require the immune system to mount a response. The drug would simply give you the antibodies needed to fight off the infection. So we're hoping that the upcoming clinical trials will demonstrate what logic tells us, that by giving the antibodies directly to an older adult, we'll be able to protect them better than giving a vaccine. Plus, monoclonal antibodies can fight an active infection, whereas vaccines cannot. Monoclonal antibodies are a treatment. The vaccines are there to prevent but cannot treat an active infection. I know we're all hoping for a COVID vaccine to become widely available before the end of the year, but as scientists, again with a long track record of experience in this field, this is simply not going to happen. And when it is ready, the vaccine is unlikely to work as well in the very people who need that protection, the frail and the older adults, than in the younger population. In addition, recent polls have indicated that many Americans, if not more than half, may actually decline a first-generation COVID-19 vaccine, again, making it much more problematic in protecting the elderly and the rest of us. So right now, this is your best protection. This is the mask that you should be wearing because this, whether you're young or old, is your current vaccine. We have clear and growing evidence that Universal masking protects you and others by preventing infections, but also, interestingly, by reducing the severity of infections when they do occur. In fact, we believe that within senior communities, our efforts to start universal masking very early on in this pandemic is a major reason why most of our cases have been asymptomatic or minimally symptomatic. Anyone who says that masking does not make a difference is dead wrong. This protects you, it protects me, and it protects everyone around us. Thank you.
Thank you, doctors. And now we'll take questions from the media. To ask a question, you'll have to go to the participants icon at the bottom of the page on your screen and press the raise your hand button. That will put you in our queue. I'll read your name and your line will be unmuted for you to ask the question. Please remember to unmute your microphone on your end as well. We will try to call on as many different media outlets as we can in the time we have allotted. So again, go to the participants icon at the bottom of the page on your screen and press the raise your hand button. That'll put you in the queue. I'll read your name to unmute you. Please unmute yourself and we'll go from there. First question, I'm going to direct to Dr. Nace. What do you tell people who say that masks don't work to prevent disease or that masks prevent the brain from getting enough oxygen?
Thanks. I know that there have been a number of concerns that people have had about wearing masks, the fact that they don't enjoy wearing those masks or that they're worried that the level of oxygen has changed. We have absolutely no evidence that masks interfere with the body's availability to get oxygen as needed. And we very clearly know from multiple sources of data, virologic data, epidemiologic data, and ecologic data, that masking does make a difference and reduces the spread and the severity of this illness.
It's important to recognize that being uncomfortable with a mask is dramatically different from the mask harming you. The number of people who cannot tolerate a mask for a medical reason is exceptionally small, and those people often are not the ones who will be out in the general public. You can talk with your doctor about ways to accommodate a mask to get the right protection for you and for others, but the answer isn't to skip the mask.
Okay, next question. Is it possible to start rolling out a safe and effective COVID-19 vaccine before the end of the year? Dr. Nace, you want to start?
Sure. With regards to rolling out a vaccine that is proven to be safe and effective, we need to know that it helps improve the immune system and that it also reduces the chance of disease. We only have a few months left in the end of this year, and we know that this would be unprecedented for us to have a vaccine available, tested, and determine that it's safe and effective in preventing clinical disease in such a short period of time. The chance of this happening is almost nil. We're hopeful that we can move as fast as we can, but unfortunately, before the end of the year, it is not likely to occur.
The three of us are proud of our colleagues in our organization that are contributing to the effort to identify a vaccine. And as Dr. Nace said, it would be completely unprecedented. This is our generation's moonshot, essentially. But at UPMC, we want to make sure that any vaccine we make available to our community is safe and effective.
Okay, let's go to the phone. Amy Wattis, KDKA. Amy, please go ahead.
Hello, can you hear me, guys?
Go ahead, Amy.
Yes, hi, how are you? Question for you. Why have we been seeing a rise in COVID cases among 5 to 18-year-olds? I know we've been getting releases from the Department of Health as well as the governor's office on this topic. And then also, we've been seeing school districts nearly every day sending out information on at least 1 or 2 positive cases in their children, different ages, even some teachers. So why are we seeing this trend happening in the state locally? What needs to be done about this? And what are doctors noticing?
So what we've noticed since the beginning of the COVID-19 experiences is that a few things. The elderly and the infirmed are the ones who pay the highest price for the infection and have the worst outcomes. And that's been true throughout the entire experience. We've also seen that the growth opportunities changes among different segments of our population often in contact with how much interaction they're having with others like them or others in the community. So it's not particularly surprising in the fall here now that children of school age have some more contact depending on which type of model their school district has gotten into, what type of other activities, that there would be an increase in activity, particularly if you're comparing it to earlier in the pandemic when with much more cloistering there was virtually no pediatric experience or exposure in Western Pennsylvania. So the numbers almost always couldn't go anywhere but up. What we're still not seeing is many bad outcomes or difficult to treat cases in that same younger population. So I'm not surprised at all that we've seen more. I think the same measures that we talk about for everyone, distancing, masking when it can be done, hygiene, not having your child interact with others when they're sick, those still make a lot of sense, and that's what I'd be focusing on.
I think we've said from press conference number 1 that pandemics are variable things. It's impossible to predict how a pandemic will go, and it's also to be expected that there will be ebbs and flows. Wholly expected as the school season started that there would be schools and school districts that would have cases. It's to be expected because transmission is happening. I think the important part about this is the response to those cases, which re-emphasizes the protections that Dr. Yealy talked about, and what I've said, that testing symptomatic individuals is critically important so that public health can do contact tracing and minimize risk of further transmission.
Okay, thank you. Next question, Paul Goff, Pittsburgh Business Times. Paul, please go ahead.
Hi, can you hear me okay?
We can, Paul. Go ahead.
Thank you, doctors, for the time. I'm wondering, with the gathering restrictions that have been ruled unconstitutional by the federal judge with Pennsylvania, and they may or may not be reinstated on a stay, what's your current medical advice about for people that are either deciding that they may want to have a gathering, some kind of event, anything that would be, with a larger amount of people? What's the science say? What do you say about keeping people safe?
SARS-CoV-2 doesn't read the legal register. It doesn't care whether there's a law about congregating or not. It's just the biology of the virus that we know that being unmasked and in congregate settings increases the risk of transmission. So whether we're talking about schools, healthcare facilities, sporting events, weddings, any other gatherings that we want to talk about, it's all about the same biology of transmission. That being in close contact, unmasked with other individuals increases the risk of transmission. And so whether or not there's a law that says, or it's deemed unconstitutional, that gatherings are or aren't allowed, I think we as citizens of the state have to pay attention to this is how the virus is transmitted. And in order for us to stay well, we need to make sure that we don't gather in large groups without masks.
I think the people of Western Pennsylvania and the Commonwealth in general have responded excellently to many of the suggestions that help mitigate the spread of the virus. Our experience in Western Pennsylvania has been very good. It doesn't look like many other places that we're on fire with the virus because people distanced. They've done well with hygiene and with masking. This is not the time to take the foot off the gas. And rather than fret about how many people can congregate, if you follow the simple instructions that Dr. Snyder just talked about, those questions become moot. How can we do things? How can we attend a game or have a function in a different way that retains the pleasure but keeps that distance, keeps us safe? You can do it, we can do it, and we can avoid further conversations about broader, blunter restrictions that really take a different toll on everyone.
And the one point I'd like to add to that is your decision to use the mask, your decision to socially distance, is not just about protecting you. It's about protecting those around you and those you don't know who are susceptible that are near you.
Thank you. Next question, Sarah Bowden, WESA-FM. Sarah, please go ahead.
Hello. So I had some tech problems in the beginning, so I'm sorry if you already addressed this. But I was wondering if you could give a little bit of a timeline for the monoclonal antibody treatment to people in senior living facilities within the UPMC system and perhaps even outside the UPMC system?
So with regards to the timeline for use of monoclonal antibodies, at this point in time, we don't have trials in process in our long-term care facilities for the monoclonal antibodies. Those are just being developed and pushed forward and will be at a time that I can't give you for the current moment. So.
We have an email question from Nicole Brambilla from Public Source. Given that COVID-19 symptoms are similar to flu symptoms, what is UPMC doing to ramp up its testing capability for both COVID and flu?
So we have begun to expand the tests for both of those particular viral pathogens, both separately and the ability to test all together. Concomitant with that is making sure that we have a plan and education for all of our healthcare providers when they interface with people who have upper respiratory infectious symptoms, teaching them how to address this in the current pandemic, what to do from testing, what to do with treatment. It's beyond just expanding testing. Not everyone with influenza will need an influenza test. We think people need COVID-19 tests much more frequently. We can manage others without specific tests. What we will do is we have increased our capacity, not only the numbers of tests available, but where they're available, and increase the planning and the deployment around that. I think that's what you're counting on from us. How do we know what to use and use it most effectively?
I'm going to add to the question. Within our senior facilities, influenza certainly can have a major impact. So that is one example of a place where we will be doing testing for both influenza and COVID-19, because that's something for which we can clearly make a difference, and we have a strong track record of doing that.
And from the very start of the pandemic, we have used what resources we can to expand testing and have done it from the start through the pandemic to the present and beyond. We will only offer tests that we are confident will accurately serve the clinical purpose that they're being used for. And at the same time, since it remains a limited resource because of issues like reagent availability, we have to deploy that resource prudently for our communities, whether that be making sure that we use the test capacity we have for the highest priority indications for COVID-19, or whether we use influenza and other respiratory virus testing to protect those who are vulnerable, to guide treatment where that decision may be made based on the test result.
Okay. So a follow-up question, what about these new rapid antigen tests we've been hearing about? Will they be important in stopping the virus? Dr. Snyder?
Start with some fundamentals. First, there are three types of tests for COVID-19. There's a PCR test, which detects genetic material. There's an antigen test, which detects portions of the virus itself, and there's an antibody test. The first two tests are used to diagnose symptomatic disease and also used to detect when the virus is present in the body. The antibody detects the body's immune response to the virus. So the PCR testing is exquisitely sensitive at being able to find the virus's genetic material. It's an incredibly powerful tool to find whether or not the virus or fragments of the virus's genetic material are present. The antigen tests so far that have become available are proving to be a less potent tool to detect the presence of the virus, and may be more prone to be wrong whether the test is positive or negative. And so we are looking to all test capacity as we can, but antigen testing, we have to take into consideration the limitations of the tests itself. And we've seen that limitation reflected, for example, in the guidance that we've had for senior communities, long-term care facilities, and nursing home facilities from the state about how to deploy antigen testing. Not quite as simple as deploying PCR testing, whether used for testing symptomatic patients or asymptomatic persons, and it comes with some caveats.
I think it's important to highlight there's not a right and a wrong test here. There are tests that perform differently, and our job is to make sure we match the test performance with the group in which we're using that. So an antigen test may be perfectly informative, even with its foibles compared to a PCR test, in a different population. It's why it's deployed differently. Our job is to make sure that we give you the test that serves the need best at that moment in time. It's why when you're symptomatic, we rely on the PCR test. It is not wrong very often at all.
Okay, thank you. Let's go to Colleen Knudsen at WTAJ TV in Johnstown. Colleen, please go ahead.
Hi, good afternoon. I had a quick question about the MMR vaccine. Some people are saying that it could suffice until there's a coronavirus-specific vaccine, or it could go hand in hand when a vaccine is created. Some, doctors and pharmacists in our region are encouraging the population who's most at risk to get a booster. Just looking for your opinions or thoughts kind of on that. Thank you.
If talk with your physician. If the MMR vaccine is indicated for you, I would recommend vaccination with MMR. We have vaccines really are a miracle of modern science in helping to prevent infection in our communities. Right now, we're not making any recommendation to substitute the MMR vaccine for protection against coronavirus.
I think Dr. Snyder hit it right on the head. Get the vaccinations that are important for your health, no matter what they are. We're often looking for some cross-reactivity. In other words, a vaccine intended for one illness might help in another. That's very attractive, but in general, the data behind that are not so convincing. We'd love to have a universal or a dual-purpose type agent. That's not the reality now. It still is a good idea if you're a candidate for an MMR vaccine to get that. Just do it with open eyes, recognizing that you can't count on protection from influenza or COVID-19 from that.
Okay. Next question, Bill Kibler, Altoona Mirror. Bill, please go ahead.
Thank you. Can somebody reiterate what I think was suggested earlier in the news conference about UPMC policies on COVID-19 protection not fluctuating, like some of the national policy changes on that?
We have focused from the very start on offering infection prevention interventions to protect patients, visitors, and healthcare workers in our facilities, period. And that is our primary focus. It's my job in particular to keep people from getting an infection while they're in our healthcare facilities. We have determined our plan based on what we know about the virus, the science that's coming out, and our own observations, the contact tracing that we do, and what we've observed about the potential risk for transmission in our facilities. I've highlighted 3 issues where there is a little bit of controversy about either public health guidance or the science behind it. And what I want to emphasize about personal protective equipment, as well as our other planning, is that we will stay focused on what we know, whether that be the science or our own observations, to protect healthcare workers, patients, and visitors, and not necessarily deviate based on rapid changes in public health guidance. In short, we are doing what we think will be protective for healthcare workers. We're taking a posture where if we think there is potentially a risk, for example, airborne transmission, we will offer that protection and recommend that protection to our healthcare workers. As the science evolves, we may learn that we have to do less. And if that happens, we will evolve our guidance as well. But for now, our focus is on protecting people in our facilities.
And I want to just add to that. I think that what's really important and what we've done here at UPMC is try to be transparent with what we're doing in order to share so that other people can learn and that we can inform the public health response to this disease.
Okay. Next question, Marcy Cipriani, WTAE TV. Marcy, please go ahead.
Yeah, hi, thank you. My question is regarding the large push we're seeing right now to bring fans back into the stands. I know that Pitt has been very vocal about bringing their fans back. Steelers certainly want to do that as well. Is there a way to do that safely? And if so, how? What's your recommendation?
It all comes back to the same things we were saying earlier, masking and distancing. And so whether we're talking about sporting events, whether we're talking about social events like weddings, funerals, whether we're talking about school, whether we're talking about healthcare setting, it's all about mask and distancing. So is it safe for people to attend those sporting events? It all depends on how well people can mask and distance at those events.
And that's why you'll often see different answers, even inside of the area of sports events. An event inside is dramatically different than an event outside. The ability to space, the ability to have fresh air around, all might influence the very specific decision any organization might make about hosting other folks. If you follow the principles and understand those, you can answer the question about school, about sporting events, about Halloween if you want. It's really the same basic principles that will help keep everyone safe.
Next question, Danny Fitzgerald, Beaver County Times. Danny, please go ahead.
Thank you. Yeah, my question is, if someone were to come to a facility, they're not sure if they have COVID or the flu because the symptoms are very similar, would you right away test them for COVID-19, or is there a separate testing for the flu? What would happen for someone who comes in and they're just not sure what they have?
So as an acute care specialist, if you came with symptoms today that were consistent with COVID-19 illness or infection, we will test you for that, period. It's important to know, not only because it guides treatment, but it helps guide when we identify people who have the infection, the advice about their behavior and the behavior of people around them. Whether or not we test for other infectious pathogens, and that includes the flu, depends first on the result of the COVID-19 test and what's happening with flu in our current area. And so we may decide to test either separately or concomitantly with it. But first and foremost, right now, and for the rest of the pandemic, I expect that we will test for COVID-19 when you have symptoms that are consistent with it.
And just by way of reminder, during a typical flu season, providers don't always test for influenza. It depends on the patient. It depends on to what extent influenza is circulating. The test itself for influenza or other respiratory viruses, non-SARS-CoV-2 respiratory viruses, whether or not that test is needed to take care of a patient may depend on the patient's circumstances and what's happening with those viruses. But I agree entirely with Dr. Yealy's statement that we cannot say often enough, if somebody is concerned that they may have COVID-19, they should be tested.
Okay, we have time for a few more questions. So again, go to the participants icon at the bottom of your page and press the raise your hand button. That will put you in our queue. I'll read your name and your line will be unmuted, and we will be able to, and you will be able to ask your question. So again, press the raise your hand button on the icon, and we'll go from there. We do have a follow-up question from Paul Goff at the Pittsburgh Business Times. Paul, please go ahead. Paul?
Yes, hi. There was a CDC report over the weekend about the percentage of the population that has antibodies for COVID-19. I'm wondering, because you guys have been doing a lot of surveillance and looking at that pretty much all along, whether you have a sense of what it might be here in Western PA, Allegheny County, any kind of localized.
So antibody testing we have left to the discretion of physicians and advanced practice providers taking care of our patients. We have not systematically done antibody testing, with perhaps one exception. We have not systematically done antibody testing. So we don't have data to say what the community prevalence of potential prior exposure has been. I will point out one thing, that when the disease is not highly prevalent in a community, even a very good antibody test, because it can be sometimes wrong and sometimes right, may not give a precise estimate for any individual person about whether they've been exposed or not. It is helpful on a population level to give you an idea about how many people in that population have been exposed.
That CDC estimate that you referred to talks about the antibodies that are present using the tests with all its limitations in the United States. As we've talked about before, viruses enter different areas and have different amount of penetration. Western Pennsylvania never had the exposure that, for example, New York did or that Italy did. So I would expect that our antibody prevalence, given what we've experienced over 8 months now, would be on the lower end, but within the bounds that you read from the CDC. In other words, I don't think you're going to find 70, 80, 90% of the Western Pennsylvania population with immunity already. I just don't think that's particularly likely. I can't tell you what the exact number is because we haven't done that surveillance.
Okay, let's go back to Sarah Bowden at WESA. Sarah, please go ahead.
Hi, so I had a question about who would get the vaccine first when we eventually have the vaccine for the general population. I know that obviously healthcare workers will get it first, and then I know that certain populations will be prioritized because elderly people have a less robust response to vaccination, even though they're also more at risk. Do you think it would make sense then to vaccinate younger people who are healthier and have less adverse reaction to coronavirus, but are also maybe more likely to spread it to more people? Because younger people, as we've seen with epidemiological data, are more likely to go out and about, go to parties, be less likely to adhere to mitigation efforts. It's kind of an interesting sort of difficult question, and I'm wondering what the science says about this.
So you're absolutely right. The vaccine may be less effective and is likely to be less effective in an older adult population than in younger adults. We sort of faced this question back in 2004, 2005, when there was a massive vaccine shortage. And we needed to look at who to give very limited vaccine to. What we know from studies that have been done in long-term care centers that have been repeated several times and looked at from a variety of ways is that when you vaccinate the healthcare workers, you actually lower the mortality of the residents, regardless of whether the residents have gotten the vaccine. We would still continue to provide vaccine to older adults. We wouldn't discourage vaccination of older adults, but we certainly would want to take a look at vaccinating those who care for them and those who are family members who may be close to individuals who are at high risk. And then beyond that, as more vaccine became available, expanding that across the population to other individuals.
My own thoughts on this are that you've asked an excellent question. You are ready to become an instructor in a graduate level epidemiology program. That's a great question. I think the bigger issue than who's first in line, particularly once we get beyond the healthcare workers, are how well will people accept vaccination? I think that'll be a bigger set of debates and opportunities for people to have conversation about than who within the non-healthcare worker population is first or second or third. And that's where I think we're going to need to know more about the individual vaccines. They're not all exactly the same. And conversations with everyone across the population about what are the risks and rewards of vaccinations in general and this particular vaccination. As Dr. Nace talked earlier, we've heard estimates that up to half the people would just simply refuse a vaccination early on. Mm-hmm. So that presents a whole nother set of problems different from whatever the pecking order is that's arranged by either scientific or societal needs.
We're as excited as anybody about the possibility of a vaccine and its ability to potentially mitigate the impact of this pandemic, but let's also put vaccine in context. It's unlikely to be the COVID-19 endgame. In other words, it's unlikely to end the pandemic for us. It'll be an important tool for us to help reduce the impact of disease and potentially protect the vulnerable, particularly the elderly, but it probably won't end the pandemic. So even as we approach news that a vaccine will become available, that won't stop the need to get tested if you're symptomatic, to wear a mask, to physically distance, and we're obviously very excited about the possibility for antibody therapeutics that our colleagues, Dr. Mellers and Dr. Dimitrov, are contributing to.
Okay, next question, Bill Kibler, Altoona Mirror. Bill, please go ahead.
Thank you. Can you talk again a little bit about what the science says now about transmission by aerosols versus large droplets? Are you saying that your experience shows that aerosol transmission is very rare?
Yes, so droplet transmission happens, and it's predominant route of transmission. Airborne transmission is probably unlikely, and we need to understand, but definitely happens, and we need to understand the circumstances in which it happens. So let me step back for a second and say, with any infectious disease, it is transmitted by some route. And it may be droplet transmission, which are large droplets that are sneezed or coughed or sung out and don't travel very far. or by small airborne aerosols, small airborne aerosol droplets that can remain suspended in time in the air for a period of time. There are other routes of transmission as well. So with COVID-19, we do talk about the role the environment plays. If a surface is contaminated, I contaminate my hands and touch the mucous membranes of my mouth and nose, could I be sick? Yes, that's possible too. There are other routes of transmission that we've already, for the most part, discounted as significant for COVID-19. Like we know that the virus could be expelled in the stool, but we're not concerned about the likelihood of fecal oral, in other words, ingesting the virus, or fecal respiratory, inhaling the virus transmission. We're also not concerned about bloodborne transmission, even though we know that the viral genetic material can be found in the blood. So this isn't really a question of, is there one transmission route? It's a question of what transmission routes are most likely. So what are our observations? Our observations are that we have done universal masking. So everybody walking into our facility is wearing a mask since early spring, the very first time that we suspected transmission may be occurring in our communities. And we adopted this intervention early because of what we know about other respiratory viruses and the science that we had at the time, which is droplet is likely predominant. At the same time, we provide and recommend protections against the possibility of airborne transmission. Now, have we observed that happen in our healthcare facilities? No. I ask our extremely brilliant, expansive infection prevention community at UPMC all the time, please give me some evidence that either our protections are not working or that you're seeing different modes of transmission than we would expect. The answer is we're just not observing it. But there's a caveat to that. In the healthcare setting, we're providing protection against airborne transmission where we think it could happen. And in the healthcare setting, we have a highly controlled environment, including airflow. Some of the studies that have come out to suggest that we should be worried about airborne transmission are entirely different settings. So for example, a study in a restaurant where people were more than 6 feet apart and many people got ill further apart. Well, that's one piece of data that suggests airborne transmission could happen. And we have to ask, what are the circumstances that transmission did happen? Was there poor airflow? Was one person particularly contagious and shedding a lot of virus? What were the behaviors of the people in that restaurant or whatever situation it is? So there will be data that comes out that suggests airborne transmission can happen. And I think it's incumbent upon science to understand when does it actually happen. I'm not talking about theoretical studies or laboratory-based studies which says, yes, the virus can remain suspended in the air. Those are important basic science, but those don't answer the question, is it likely to actually happen in clinical practice? And I'll mention that we have been through this debate before with influenza. For years, the debate rolled on that whether or not it was droplet or airborne transmission or what the relative contribution was, in part because of some of these similar scientific studies that we're seeing with COVID-19 about the possibility of airborne transmission. And we ultimately came to some high-quality clinical studies, plus all of the observations from infection prevention communities around the world that said it's not really airborne transmission, it's droplet transmission. We'll see what the science says about SARS-CoV-2 and what contribution airborne transmission plays, but I wouldn't view it as it's either droplet or airborne. And we're offering protections for the possibility of airborne until we know more.
Last question. Last week, the Commonwealth of Pennsylvania released a COVID contact tracing app. Is UPMC advising its employees to use it? What's your opinion of it?
We absolutely think that any tool that allows us to help mitigate spread of COVID-19 illness and infection is a good thing. The Commonwealth application has been not only promulgated by the Department of Health, but also here the Allegheny County Health Department. I think it's a great idea. I actually have it on my own phone. Mm-hmm. All of us are part of the community, even when we're outside the hospital. And this is one additional tool that will help us. It won't be the silver bullet, but it's another tool that allows us to identify not only who has the illness, but who they came in contact with, and do so in an unobtrusive way. We've encouraged our staff and our physicians to download this. The University of Pittsburgh has done the same with students and staff, and we think you should be open and be downloading this too.
And while we're encouraging the UPMC community to be good citizens, whether that be participating in this app, I too downloaded the app as soon as it became available, or whether that be being conscientious about non-work-based activities and the transmission risk they may entail, we still do contact tracing within our facilities and partner with our public health colleagues to extend those contact tracings outside of our healthcare facilities when they may overlap.
Okay, thank you. Thank you all for participating in our 22nd COVID-19 press briefing. In about 45 minutes, we will email to the media a link to download high-definition footage of the entire press briefing, which we encourage you to use in your news reports. Anybody with a follow-up question can contact the UPMC Media Relations Department at upmc.com/media. And please remember to follow @UPMC News on Twitter for frequent updates. Thank you.